You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hi, everyone. Welcome to CRST, the podcast. I'm Dr. Nandini Venkateswaran. I'm a cataract, cornea, and refractive surgery specialist in Boston, Massachusetts. And today we're taking a deeper dive into CRST's recent issue, which was entitled Cornea Conscious Surgery. And this issue really focuses on the cornea's pivotal role in cataract surgery. I had the privilege of serving as the guest medical editor for the issue, and I'm thrilled to be joined by two of its exceptional contributors to continue the conversation. I'm here with...
Hi guys, it's Joaquin de Rojas here from Sarasota, Florida. Thank you, Nandini, for inviting me on. I'd love to talk a little bit about my experience with everything. I know I'll be learning a lot from you two guys.
And I'm Mina Farahani. I'm joining from Boston, Massachusetts. I'm a cornea specialist at Ophthalmic Consultants of Boston. Looking forward to learning more from you and to discussing optimizing the cornea.
It's great to have you guys, and I think we'll delve into each of your articles into a little bit more detail and get some insights. Dr. de Rojas is going to be discussing the importance of adopting a refractive mindset when approaching cataract surgery, especially when we think about those patients with irregular corneas. And Dr. Farahani will share some great insights into optimizing the ocular surface for our cataract surgery patients and really emphasize why it's important to think about dry eye disease in this patient population. So let's jump right in. Joaquin, I loved your article, and I think in this day and age of cataract surgery, having a refractive mindset is so important. I think our patients' needs and demands are just constantly increasing, and as they should. So as a cataract surgeon, how have you started to adopt that refractive mindset when you see your cataract surgery patients, and how has it affected your patient outcomes?
What I had the privilege of writing about in this article is really what's going on in all of our minds these days as cataract surgeons is we are refractive cataract surgeons. It's really nothing unique to what I'm contributing other than I think it's nice to explicitly think about the mental shift that has occurred in the field of cornea surgery and cornea care, where you're really now thinking about refractive outcomes, where maybe that wasn't as true in the past when the real outcome was sort of the health of the eye, let's say. So now we're really thinking about the refractive outcome. And why is that important? I kind of always go back to, because really it's what our patients want, and when our patients come to us, they want to see better and they want to have freedom in their life. Sometimes that means freedom without glasses and just better functional vision. And that's really what refractive surgery is all about. So when I think of a patient, I'm always thinking in the refractive mindset because I'm always thinking about how do I improve their function? How do I improve their life? And how do I make it easier for them? So I think that you can always have a refractive mindset. You have to take care of the disease. You have to take care of everything else. But I think if you want to take it to the next level with your patients, you have to have that refractive mindset because ultimately that's what's going to make you successful and your patients happier.
Absolutely. And then, we're all cornea specialists here, and these are some tough cases, right? They come to us, they've been referred, they may have pathology, and others may say, listen, your only option is a monofocal lens, and we're not sure what the outcome will be, but we'll try to get you seeing clearer, and then we'll get you glasses or contacts. And I think that's reasonable for some patients, but how do you now navigate that conversation? We've had this influx of technology. So when you see this irregular cornea patient, what's going through your mind and how do you help perhaps give them a refractive outcome?
Yeah, so I think you have to take every case case by case because it's really a tailored approach that I try to pursue, considering sort of that patients where they're coming from, what is the condition of their ocular surface, what is the condition of their cornea, and the rest of their optical system, all the way, really, how does the light go all the way to their retina? And you're considering that whole kind of segue of light. And I think that that's really step one is to try to understand what is the patient's condition, and then also what is the patient. Step two is what does the patient really want. So if I determine that they have some pathology, whether that's, let's say, severe ocular surface disease, maybe accompanied by rheumatologic disease, or maybe it's exposure keratopathy. There's a whole host of issues that some of which I talk about. But you determine it, and you ask yourself, can I improve the condition to increase the candidacy of these for these technologies? So that's always kind of what I'm thinking, and especially if that's what the patient wants. So first, I determine if it's possible, okay, and if I can optimize the situation, I try to do that first. And if I can't optimize the situation, then you have to really take a deep dive and look at both. I would say your exam findings, which are more kind of qualitative, but also look at some more kind of quantitative data from things like the pentacam, from things like the arc scan. There's all these different wavefront aberrometers now and autorefractors, all sorts of different tools that you can use to try to quantify sort of the visual quality that you might get after surgery. And once you determine these things, you kind of start thinking about what the patient wants, and you think about the tools that you have, and you try to match it to the patient. It's always kind of think of it as like you have to have a proper level of confidence in the technology, but you also have to, and in yourself, to be able to deliver the outcome to this patient. But you also can't be overconfident and promise the patient the world, because that's kind of a recipe for misunderstanding and an outcome that you're not proud of. So you have to have that right balance where you're really confident you can get the patient there, but kind of under promise and over deliver.
I think that's so important, really expectation setting in this patient population. I'm sure we have many listeners here who may want to start to offer, different technologies for patients with, more compromised corneas. Mina, what do you think are some of the tools or the key tools that we may need in a practice to start doing that? What are some of the key equipment or key testing that you really rely upon when you're stratifying patients?
Well, just like what Joaquin said, we really have to look at the entire optical system from the front to the back. So, we need corneal imaging. We need to look for higher order aberrations. I always get an OCT of the macula for all cataract consults because there may be some subtle maculopathy that we may miss with just a dilated exam. And so I include that as part of my workup for every cataract who's coming in, whether it's a patient who's considering a more premium lens implant versus just a monofocal. I want to make sure that there are no surprises on the in the post-op period. And so having a way to view the cornea, whether it's the pentacam or whichever way you're going to measure your Ks in a few different ways, looking for inconsistencies along the way, and getting your IOL calcs. And I would definitely add an OCT of the macula. I think that that's really the basics. That coupled with a very careful slit lamp exam. And as I get into in my article, we have to really look for keratopathy, look for corneal abnormalities like ABMD that could cause or induce irregular astigmatism that may need to be addressed with a superficial keratectomy to optimize the surgical outcome. If we miss these things on the front end, we can have post-refractive surprises on the back end. And the patient may think that you gave them a new problem instead of missing something that was there all along. And so I think that just a very thorough workup from front of the eye to back of the eye to be able to set realistic expectations is so, so important.
Absolutely. I mean, I rely on my topography and tomography for almost every patient. So having that information in conjunction with biometry and sometimes even aberrometry with some of our more advanced technologies can be great. So I
And
think
just
that's
like
really
just something to add, I'm sure we all do this, right? It's don't be afraid to order tests even if you can't bill for them. Because sometimes it's what insurance says we should bill for is not necessarily what's going to be most optimal or that we can bill for, right? Because we do, like you said, the OCT max. You may not find anything back there half the time, but you're going to be happy when you do. And obviously, even if you do, you can't bill for it if it's a screening test. So, but it's still worth it. It's because it's the right thing to do for the patient. So you want to establish a system in your clinics where you can have these patients as efficiently as possible get this testing that you need. And like Mina said too, I agree with her 100% about the slit lamp exam because you can also, let's not forget, you don't need all the fancy testing all the time because a lot of things you can figure out just with a good slit lamp exam. And I do believe that to be true.
But I think pictures speak a thousand words. There's many times I get a topography, tomography, and I'll see areas of flattening or steepening, and I'm like, that's interesting. Then I'll go directly to that part of the cornea on my exam, and you'll find, subtle anterior basement membrane dystrophy or a Salzmann's nodule hidden under the upper eyelid that others have missed. And these things can induce a lot of irregular astigmatism. So optimizing the surface and trying to get better keratometry values can be so important for the patient's outcome because that may change their candidacy for certain types of lens technologies. I saw that in my clinic today. So I feel like really using your imaging and showing your patient what it is that you're noticing can really help them understand why sometimes it's not just a one and done, like let's do cataract surgery next week. We may need to think about doing this in a more stepwise approach. And they're more receptive to that, I
Yeah,
find.
those are such gratifying cases for me when I pick up a lot of irregular astigmatism. And they may read okay on the chart. It's probably a really lousy quality 2040 or 2030. And you get that pre op topography picture, and I walk them through the picture. I pull up that first image and I explained it's like a land map. Blue is flat like water, green is like land. And look, you have this yellow hill and this red mountain on your cornea, and it should all be one even color. And I show them that picture to explain the concept of irregular astigmatism, how there's every color of the rainbow in their central cornea, and it shouldn't be that way, and they get it. And then when I do a procedure and repeat that picture in the post-op period, I usually get another one at month 1 after a keratectomy. They see that difference instantly, and it's really, it's gratifying for both of us to know that, okay, you had these lumps and bumps, they're gone, and now we can move on and possibly address your cataract if it's significant too. And you'll do better because we dealt with this first. So I think patient education is just so important uh, for uh, for these patients where you may have to delay their surgery. They need to know why, and that you're doing it for basically to meet their vision goals ultimately.
It's so gratifying too when you either treat like their ocular surface or you do a SK like you said, and you get their vision better even before cataract surgery. That's always fun because then they're already, oh, I'm already seeing better, and then we kind of can take them to the next level. And
Exactly.
so, and then on the flip side, there's nothing worse than doing the surgery and then you see these issues afterwards, and then you have to try to explain to them that they have issues that whether you did the surgery or someone else did the surgery, that maybe were missed. But you don't say it like that, obviously. But that's always a tough conversation because they're like, did the surgery cause this? That's always the next question, and it's going to be on their mind.
Absolutely. I've even had patients where I've, say, done a superficial keratectomy and they're so happy after they defer cataract surgery for 2 years. Well, another thing that comes to mind, we have all of these new lenses, right? The small aperture lens, the light adjustable lens, enhanced monofocal. And I think they can all, play a role in patients with, you know, irregular corneas if they're the appropriate candidate. Joaquin, have you used any of these technologies in such patients? And have you had an interesting case that comes to mind where the patient was really happy with the outcome?
Yeah, definitely, I have. And it started. We didn't have like a few years ago. We didn't have even LAL. We had like basically monofocals, torics, and we had like multifocals, EDOFs, right? And then you really are limited. You try to improve the ocular surface and do everything else, and sometimes you're successful. A lot of times you are, but sometimes there's just something there. The patient has 16 cut RK, corneal scarring. There's not much you can do there, right? So then the LAL came out, and that's been really nice because at least um, get you can take corneas that are going to be difficult to predict the refractive outcome, and you can really minimize that refractive outcome and have confidence you're going to hit the target. But then, that has some limitations too, right? Because it doesn't really address irregular stigmatism. So, you have to be careful if it's like 16 cut RK or more, or if there's a component of the stigmatism that's pretty irregular. And like I talk about in the article, there are ways to figure this out, pretty simple ways that everyone should understand, looking at the manifest refraction versus like a hard contact lens refraction, looking at topography, all these type of things. But then the IC8 came out, which has been really great for patients that have a lot of irregular astigmatism. I think that's been great because now we have a premium surgical option for irregular astigmatism that's lens based. We've had topo guided LASIK and these other things, but but a lens-based option, it's pretty awesome. So I had the first patient I did. It was someone that, talk about a refractive mindset. He made me have a refractive mindset because he didn't want surgery until the ICA came out. He was very well researched. We got the lens. Patient was ecstatic. We called him up, and he had a 16 cut RK. Luckily, he had done a pilocarpine. I wouldn't even call it a challenge because he was just living with pilocarpine. He was just using pilocarpine regularly, and it was helping him. So that was awesome. First patient to do this on. I did it bilaterally, which I know that the indication is actually in one eye. Uh, but I think in this case, the bilateral approach would have been ideal for him at the time. That's what I thought, and I was right because he basically the way I approached the case was I targeted about negative 0.75 in the dominant eye, which I find is a really good target if you're kind of looking for good distance vision, because that's kind of the midpoint of the midpoint refraction, because the pinhole will give you about 1.5 diopters of range. So if you target that negative 0.75, you get on the one end, you get emetropia, you get like the plano 2020, and then you can go all the way to about negative 1.5 for near. So you can do that, and then if you want any more near than that, then you can target more near, like a minus 1.5 or so in the non-dominant. So that's exactly what I did for him. And within a few days, I mean, I think I saw him day 4 after both eyes were done. He's 2020 J1, and it's been pretty awesome that I could get him like that. And then another patient I recently also did was with the IC8 was a patient with scarring from herpetic disease in one eye. So I did the IC8 in that eye. And then I did like a EDOF in the other eye, and that patient's doing really well, dude. So I've been really happy with the lens. You have to obviously use, like, if you have like a lot of RK patients, which you might with like 16 cut, then you have to go through the sclera for that. That's the only thing, just that's a little different, and because it's about a 3.2 millimeter, 3.0 about millimeter incisions. It's a little bigger incision, and you may have to go through the sclera depending on the case. But other than that, it's pretty straightforward. So I liked it. Have you guys had any experience with it yet?
I haven't yet. No. That's a great case. So the patient was using Pilo to basically induce the pinhole effect on his own to reduce his own irregular astigmatism in your case?
Yeah, he was a really smart
That's
guy,
neat.
and really really well
Smart guy.
read. I learned from him. I was like, yeah.
Yeah.
So he was the one that got me to get to get the lens in my hands. So sometimes our patients are the ones that teach us stuff too. You know.
That's so true. Are you going to do a Pilo trial before you place an IC8 in other patients to see if they can?
I think I am. I think
It makes
that
sense.
I think that if I'm ever going to do a bilateral, you worry about it's a pinhole, so you worry about light, not enough light getting to the retina. So I think that in those cases, I think a pilot challenge might be really nice. I think if you do it in one eye, maybe it's not necessary, but I think for bilateral, I think I'm going to do it every case. Yeah.
And of course, like using these using the IC8 in these types of eyes is obviously off label. So if you can show the patient what they may potentially, experience with the lens, I think that's important because they're paying out of pocket. You have to set the expectations, right? Sometimes we're not sure exactly what the outcome will be, and I think that is an important conversation to navigate with the patients because sometimes we may not achieve the outcome that we were looking for. So being able to think about a plan B and a plan C and what that'll look like is of course important. I had a very successful experience with the IC8 in a 16 cut RK. He was my first patient, and he actually had a really nice, central myopic flattening with very little astigmatism. So he was kind of a nice candidate because I was like, I don't know if I want to push the limits beyond a diopter and a half of astigmatism that you measure. But he was J2 and 20/30 distance, and he's thrilled. And I'm actually going to do the same thing for his other eye. And so he's very motivated to have the small aperture in both eyes. So things to consider. I mean, I think it's been a really wonderful technology to add to the armamentarium, in addition to the others that we have. Mina, any cases that come to mind for you or?
I haven't had an opportunity yet to get an IC8 case, but I'm really inspired after talking with both of you. I am also hoping maybe soon to have some access to the light adjustable lenses, but again, that's something that's not in my toolbox right now, and so I'm kind of have all access to the lenses, but those newer technologies are something that some patients are coming in asking about now. So I think that we all have to have this refractive mindset. And if there's a patient that's wanting these technologies and I personally not able to offer them, I will refer a patient out, for these because I want to be able to meet the patient's goals and know that if it's a lens that would suit them better that I can't offer, or a technology that they want, I think that we really should be referring out to get these patients in the right hands. And so I think knowing our own limitations and knowing when to send out is important. I have some patients that are sent over to me from surgeons that are not offering multifocal lenses. They may not feel comfortable in offering some of the trifocal or even the extended depth of focus lenses. So I'm happy to fill in that void for some of my colleagues as well. So just knowing what works in your hands, what you're able to offer confidently, like Joaquin said, with your own skill set, and refer out if it's something that you don't have available to offer. I think it's important to have an understanding of that.
And one thing that I was thinking back to, things we've discussed in these articles in this whole section. One thing that you don't have to have every piece of technology, as you guys because the idea is to try to work with what you have and try to really figure out kind of algorithms to in your mind to classify which patients are going to do better with what. And one thing that's often overlooked too is just like if you have to stick to monofocals or torics, and that's fine, because it's just not smart to do a light splitting lens. It's you could do like a mini monovision, blended vision approach. You could do a contact lens trial with it, and it's amazing. You can have the refractive mindset working with tools like that, and it's amazing what you can achieve just from playing around with different I guess different degrees of blended vision. And then there's really a continuum with these different EDOFs and multifocals. I'm sure as I'm sure Mina's very aware of, like, and some of them seem to be a little more forgiving than others. You know, so there's still so many. We're so lucky to just have so many possibilities.
Absolutely. And probably more to come in the next several years. That's what's really exciting. Well, I want to shift gears to Mina's article. Mina, I loved your article on kind of optimizing the surface, especially in our dry eye disease patients before surgery and then thinking about it after. Just talk us through, what are the key signs that you're kind of looking for when you're seeing these patients in clinic? Like, when do you decide you need to treat them? And when are scenarios where you say, maybe we don't have to think about, the ocular surface findings that we're seeing? How do you think through that patient in your clinic?
Yeah, so those are some great questions. So the first thing, it really starts even before I even see the patient. And so my technicians are used to working up cataract patients, cornea patients, and a lot of dry eye patients as well. And so a patient may be coming in for a cataract consult, but they're complaining of fluctuations in their vision. They're complaining of grittiness, foreign body sensation, maybe a lot of epiphora as well. And the technicians know before the patient even sees me or before they get any lens measurements or anything, that it may turn into a dry eye consult. And I may see the patient first before they go for any of their testing to check their ocular surface before they get their pentacam and their OCT and go down that whole path. It may end up turning into a dry eye consult. And so the techs have a high index of suspicion just based on symptoms that they're all very familiar with, to have that initial screen. And they may give the patient a speed to a validated dry eye questionnaire at that point and have them work on that while before I even see them. So I think that's the first thing, just having everyone on your team having a high index of suspicion that dry eye is everywhere, as we all know. And if you don't pick it up in the pre-op period, then it's a post-operative problem or complication. That's how a lot of patients can view it. I see a lot of patients that are referred to me for a dry eye consult after cataract surgery, and they are convinced that their cataract surgeon caused their dry eye. So if it's not a discussion and a workup beforehand, you don't want to be the person giving them a new problem. You're there to help them with their problem, with their vision problem, with their cataract, but it has to be addressed. And so that's the first thing, just making sure that we're getting a thorough history, having high index of suspicion before the ophthalmologist even sees the patient. And then once I see the patient, I, of course, do corneal staining. I check their lid position, looking for keratopathy, especially not only SPK, not only superficial punctate stain, but also lumps and bumps, nodules, pannus, atrigia. Just looking for anything that could be affecting the ocular surface, either measurement-wise or leading to discomfort or worsening post-operative symptoms. And so on exam, looking at the lids is also so critical. Actually pressing on my meibomian glands, looking for sleeves or collarettes at the bases of the lashes, looking at lid margin telangiectasia or inflammation. The tear breakup time is a really great measure of the health of those meibomian glands. If their tears are evaporating within seconds, they're of course going to have blurry vision and fluctuations. And that may be contributing to a lot of their visual complaints more so than their trace NS cataract. And so figuring out what's from the surface and what's from the cataract and weeding out what's actually going on causing their vision complaints. So history, getting a questionnaire is often helpful too. And then a really focused slit lamp exam, even before getting any measurements is really important.
Absolutely. I mean, even for me, my technicians will come up to me and say, "Hey doc, like I had to put a bunch of artificial tears in order to get good biometry or good topography." And I'm like, "Okay, noted," because I'm pretty sure they're going to have a very unstable surface. And if I can get the printouts of kind of the smudge circles that you get with your biometers, or you see the
Mm-hmm.
disruption
Yeah.
of the Placido-Disc-Myers on topography, that's so illustrative for the patient. I'm like, look at this. Like, I can't get nice, perfect circles, or I can't get, crisp images. That can explain why you can't see crisp when you're trying to, blink and accommodate for that. So I think that's so key, getting buy-in from your staff to help,
I love
help
that.
you
Yeah,
Yeah.
it's I do
Yeah.
that
Or
so much too.
when they're getting refracted and the technician will say, this was a really tough refraction. I kept having to have them blink. I put in some artificial tears. They can pick that up, pretty quickly. If it's a really tedious refraction and they're just kind of chasing the whole the whole phoropter with the refraction, that's a huge clue.
So patients will come in and they'll be like, I want cataract surgery tomorrow. And you see a ton of dry eye. There's so much now available in the dry eye space. How do you decide what you're going to start? Like, what are some of your, top treatments that you think have a good onset in terms of efficacy to help patients rehabilitate their surface?
So I really have two goals. I want their cornea clear so that I have a nice smooth surface and I know I can get accurate measurements. And the second thing is a comfortable post-operative course. If they're already really symptomatic with dry eye, I'm going to be, potentially putting drops with preservatives on their surface for, weeks at a time. I definitely can make their symptoms a lot worse and give them a new problem, which I don't want to do. So I want something that's going to be quick in onset, is going to be tolerable for them as well. So I can get them to the point of measurements and cataract surgery as soon as I can. So a lot of it depends on what's going on. As we know, most dry eye disease is mixed mechanism. There's very few purely aqueous deficient patients that are out there. There's very few that are purely MGD just alone. There's a lot of mixed mechanism there. So, but at the root of all of it is a loss of tear film homeostasis. So something is off. And when there is this loss of homeostasis, we know there's increase in cytokines and there's an increase in inflammation. And so the root of the key really to treat dry eye is to restore this homeostasis and to fight inflammation. I often get an MMP9 test in my clinic for patients that are coming in for a dry eye consult, or these cataract consults that turn into dry eye consults. My technicians will get an MMP9 test looking for this common marker of inflammation as well. It's helpful not only as a objective measurement for me, but also to explain dry eye and inflammation to my patients when I'm talking about it with them. And so There are a lot of drop options. There's even a nasal spray option, but I'm looking to see what's going on with the lids, what's going on with their tear film, what's going on with their tear evaporation rate, and make a decision based on that. Steroids, because inflammation is really at the key, a course of steroids can be really helpful, but they're not going to be a good long-term option. And so, with steroids, I'll often do a mild course of allodiprednol, drop for a few weeks, and I know that that will help improve the cornea, get inflammation down quicker. But as I tell my patients, as we all know, you can't be on steroids forever. They'll make the cataract worse, which is fine. We're going to address that anyways, but they can induce glaucoma at the same time, and that's a blinding disease. So we don't want to treat your surface problem, give you a long-term vision, lead to vision loss long-term. So they all get that. So I'll start steroids, but at the same time, start them on something that will be safer for long-term use. With the drops that we have on the market, we have Restasis, we have Xiidra, we have Cequa. We have these options that each have their pros and cons. When I have all the options based on insurance coverage and all of that, I find that Cequa does best in my hands just because I know that within a month of being on it in the studies, we see that there is total clearing of the cornea around that 1 month point. So I'm comfortable starting patients on that. I also find it has the best tolerability compared to the other drops. And so that is a drop I'll commonly go to. There are some patients that can't tolerate any drops on their ocular surface. They may have trouble tolerating even artificial tears. And so, fortunately, we have the Varenicline nasal spray Tyrvaya available, which is a nice option for those patients with a twice a day nasal spray that increases tear production and increases Schirmer scores. That's really a great option for those patients with tolerability issues. And also around month 1, there were significant improvements in keratopathy seen in their clinical studies too. So those are two that I'm kind of leaning towards when I have those mixed mechanism patients that we need an increase in their tear production, but also some anti-inflammatory benefit at the same time. And then, like I said, most patients do have mixed mechanism dry eye. So if you're ignoring the lids, you're really not treating a major part of their dry eye. And so, lid inflammation may be helped with some of the anti-inflammatory drops as well. But for my ocular rosacea patients, I may have to go and use some other tools in my toolbox, like topical or oral azithromycin or oral doxycycline. Or I find intense pulse light therapy to be very helpful in my clinic for these patients when we have all of that very active lid telangiectasia that we need to address to improve the quality of the meibum. And then for patients with stubborn clogged glands that aren't improving with conservative measures, or even for those patients that are getting improvement but want something quicker, heated meibomian gland expression can be very helpful. So in my clinic, I use the tear care device and find that to be very well tolerated by patients and also able to get them to that improvement in their meibum and improving their tear breakup score quicker than just a home care regimen alone. So it's really a matter of looking to see where are they at on the spectrum of aqueous deficient and evaporative dry eye and tailoring the therapies along the way.
Yeah, it's a great overview of the different options. And I agree, it's so customized based on patient's presentation and what you're seeing on their clinical exam. Joaquin, when you start to optimize the surface, do you kind of have a timeline after which you bring the patient back and check in with them before proceeding with surgery? How do you time that for patients?
Yeah, it's a good question. So I have a kind of like a go-to that I use, and sometimes it works, sometimes it doesn't. But at least I think it's important to have kind of a default that everyone's on board with. I think it helps with efficiency because it can be really it can really bog your clinic if pretty soon you have a cataract consult that turns into dry eye management for like 6 months, right? And that's that can be tough. And sometimes you have to, but a lot of times what I do is I tell the patient to come back in 2 to 3 weeks for repeat measurements. So I agree with Mina. I add a steroid. I think that's so important most of the time, right? Not all the time, but if I'm having a patient come back for measurements, it probably means I'm adding a steroid because I want really quick improvement. And I'm probably doing punctal plugs. I'm probably doing. I'm looking at their lids, looking for exposure, looking for lid disease, all the things that Rena talked about. But yeah, 2 to 3 weeks, I have them repeat the measurements. And often what I find is that if you look at the IOL master, whatever biometer, you'll find sometimes that the measurements radically change. The lens power is different. The astigmatism has gone down. I look at the Pentacam too. I repeat the Pentacam. And then if there's sometimes if it wasn't too severe, and we have a good dry plan in place and the measurements look better, I might just keep that visit as a tech only. I might even just say we're good to go. It also depends on what technology I'm using, right? If I'm going for like a multifocal, like I'm going to be a little more hands on there, and I'm going to take a look at that patient. But if it's more of just like I'm optimizing for like a toric, then I'm a little more lenient, right? So it just kind of depends on the technology, or even LAL. I'm a little more lenient. So yeah, I would say 2 to 3 weeks, because then at that point, some of the latest studies with even Sequa, showed that after 2 weeks there is an improvement in the corneal staining, which is really my biggest priority pre-op, is to improve the corneal staining and tear breakup time, because that's part of the visual axis, right? So 2 to 3 weeks, and then I look if things aren't adding up, or if I felt like I'm going for something pretty aggressive in terms of surgical treatment with like multifocals, or the patient had really severe disease, then I'm definitely going to take a look again, 2 to 3 weeks later. And it may be the case that I make a determination. I kind of make a determination after 2 to 3 weeks. If I can't get them significantly better in 2 to 3 weeks, that means I probably have to reassess how aggressive I'm going to be in terms of technologies. So I may, because what are the chances you may get them, you may work your butt off, for lack of a better term, for 2 months with the patient to try to get them really optimized, and you get it after 2 months. But who's to say that patient's going to stay on all that stuff?
100%. I feel like you need to get buy-in from the patient to sustain the regimen that you've started pre-op, post-op, because more likely than not, they will have dry eye after surgery, whether or not they started with it. But if they started with it, I promise them they'll have some dryness after. So it's nice for them to have a regimen. So if I'm starting a steroid, I like to start something that's more long-term therapy, that's steroid sparing, because then I can say continue that after. You're already used to doing this before. We want you to have that same quality of vision after. And I think patients understand that. They think of it more like a chronic process rather than just one little metric that we're trying to perfect prior to surgery. But I see plenty of patients who come afterwards. They've had, premium lens technologies put in, and they have a terrible ocular surface, and it drives them crazy because they just don't have that quality of vision. And some of those dysphotopsia symptoms are exacerbated by the fact that they have keratopathy and an unstable tear film. So
And in that same light, as you were saying, like, if you're doing your own management post-op, then it's easy because you're going to switch over to Sequa or whatever from the steroid, and you have your. But if you're co-managing a lot, in my practice, we do co-manage a lot. Then you have to have everyone's buy-in, not just the technicians, but also the co-managing optometrists, and you have to either discuss these things with them beforehand, and you can even write in your notes like, okay, after you know steroid, make sure patient continues on XYZ treatment, post-op. Sometimes you really have to be explicit because, not everyone is as enthusiastic about dry eye treatment, and I think that sometimes you catch these patients like, 3 months post-op or something. You're like, what happened? You're not doing any dry eye treatment anymore. So that's just another thing I've kind of learned.
I totally get needing to be efficient, in our clinics and optimizing dry eye within a certain amount of time so we can get to those cataracts sooner. But I do have to say, some of my most gratifying patients have been patients that have had really horrible ocular surfaces that we've worked together for months, 6 months, gone through 4 sessions of IPL, worked really hard to improve their candidacy for lenses, and have done really well with multifocal lenses. And some patients, if that's the technology that they really want, I'll give it my all to try to make their surface as pristine as I can. And if I may not get there, and I set that realistic expectation from the get-go. But for those patients where I'm able to get to that endpoint, improve their surface, and they're a candidate for a multifocal lens platform, those are really gratifying cases at the end of the day.
Mina, what are some of the new, therapies that are in the pipeline or currently almost available that you're excited about for ocular surface disease treatment?
Yeah, so it was an exciting summer, early fall here for dry eyes. So Xdemvy was approved in late July for Demodex blepharitis, the only FDA approved treatment for it now, which is exciting. I used to just depend on tea tree wipes and lid hygiene and maybe offer a Blefx here and there, to just clean the lid margins. But now that we have something that actually kills the mites themselves, I'm very encouraged. I've started several patients on it, haven't seen anyone back yet after the 6-week course, so still waiting to see. But haven't gotten too many messages about tolerability issues yet, which is good. And my patients have been able to get it, which is the other thing that's good for any new drop that's out there. Knowing that we can get it in our patients' hands is also important. But in the data, there was an improvement in not only mite eradication, but also the collarettes, even without any lid hygiene on board, without using any of these tea tree wipes or scrubs. And eyelid redness also improved, and it was sustained out to a year. So that was very encouraging. So to know that there's something we can do to target lid inflammation more, that's something exciting for me from the dry eye perspective. And then the other newcomer on the block, Mibo, is really targets evaporative dry eye by having this interface between the air and lipid and decreasing tear evaporation. And in their trials, I was impressed that the cornea was clear by month 1 with QID dosing of this molecule. And so I haven't seen, I've ordered it just a couple times and haven't seen any patients back. It's been available just a couple weeks, I believe now. So it's brand new, um, and have been able to get it in the hands of a few patients here too. So looking forward to seeing how that changes my management of dry eye. Clear cornea in a month. I mean, I think that's pretty great for these really tough eyes that can take a while to get there. Um, and so I think that would be a great option for evaporative disease as well. Have you guys had any experience yet with either?
Yeah, I, like you, have prescribed, several prescriptions for Xdemvy and about 2 or 3 for Mibo. So I'm looking forward to seeing how they do. I'm asking them, always when I prescribe something newer to my patients, I always tell them, like, I'm learning from you. So please give me feedback. Like, tell me how it feels. Tell me what you're noticing, like adverse events. I really like to follow and see them and see what are their lids looking like? What is their tear breakup time looking like? And I learned so much about how to utilize that, treatment in my practice. So looking forward to them to come back, hopefully in like 4 to 6
Yeah,
weeks.
I'm on the same boat. So yeah, prescribed to a few patients, both of those. I guess it'll just be interesting, as we're talking about the pre-op setting, just how do these work into that? And I haven't figured that out yet. I'm just trying to see how they work first. I could see potentially my book having, a role pre-op if the tear breakup time is like a big issue for measurements. It'd be interesting to see how it could improve, measurements. The Xdemvy, I'm not really sure. I mean, I don't know. What do you guys think? I think blepharitis is more, when you were talking about, Mina, the 2 reasons why you treat dry, and you were saying that one of them's for the cornea, one of them's for the symptoms, basically. I think it takes pretty bad blepharitis to really affect the central cornea. Most of the time it's more like inferior, but like your run of the mill blepharitis, I feel like is usually more represented in symptoms like burning and things like this. So I wonder if I'll be using that one as much pre-op, but maybe it might be one of those things that I could start pre-op in the bad cases and keep them on afterwards too. What are your guys' thoughts?
Yeah, I think I would think of it pretty similar, really to help with the symptoms. I want to do something, get them on some lid hygiene compress, maybe a procedure, heated meibomian gland, expression, something to deal with the obstruction and to deal with the inflammation. And so, if their inflammation is really coming from all these collarettes and from Demodex itself, then it makes sense that doing Xdemvy is going to improve their lid margin, improve their meibum, improve their tear breakup. But I think it would be a longer process than starting a steroid. So, but it's nice that we have something that's a 6-week set course to target their Demodex instead of saying, okay, here are tea tree oil wipes that you'll be on forever or, a year or two. So I really like that there's that finite amount of time with XMB and with Demodex treatment now. So I think that that's, a different way to think about it, which is exciting.
Yeah, along that same vein, I was thinking about, what is like, how long will I be keeping patients on MIBO? I'm not sure. You know, I was going to say the same thing for XDEMVY. It's nice to tell patients, 6 weeks, that's the life cycle of the mite. We're going to try to eradicate them, keep you more comfortable, and then let's see if we need to do another, course. MIBO will be more interesting to kind of see, is this more of one of those long-term therapies like we're doing with our topical immunomodulators and nasal sprays, or something more short-term? So I think more to come and more to learn. But I agree with you. I think there are those patients with, Demodex blepharitis that have a lot of, follicular conjunctivitis, epiphora, kind of, concomitant symptomatology from that lid inflammation. And I think they would really benefit from this, because often these patients are tearing and blinking and they just can't quite, achieve that clarity of vision that they're looking for. So it'll be great to slowly implement into our practices. But I thought this was a great discussion. Thank you so much to both of you for wonderful contributions to the CRST issue and for such a great conversation. And I really hope all the listeners enjoy this. And if you all want to check out the full articles, don't forget to visit www.crstoday.com, and you'll access the entire September issue on cornea conscious surgery. Thank you all for tuning in.
For more shows like the one you just listened to, check out the podcast channel on itube.net.